when you do these procedures to sort of take care of that part of the matter.
Okay, I think in the interest of time, we need to move on to the next session. Thank you all the speakers. Wonderful job. And I think on a Sunday morning, we are having quite a good participation. Roughly 150 delegates across the country are watching. At this juncture, I would like to welcome Dr. Archana Rao. I can see her there. Good morning.
Morning, all.
All good? Here,
all good.
Let's move on to the next one. Thanks to all the chairs and the speakers. And Dr. Shanmugh Sundaram, Dr. Archie, Lawrence, you guys take over and please conduct the last session of the meeting.
My sincere thanks to the.
Good evening, everyone. I think we'll move on to the next session on heart failure symposium. The first thing is regarding this SCD risk stratification. Dr. Dandabani sir will deliver the talk on SCD risk stratification. It's over to you, sir.
Organizers of this conference, my dedicated wishes and thanks to all attendees. Let me go to the subject. Sudden cardiac death risk stratification. Here, the sudden cardiac death, the important things to be noted is natural death from cardiac cause in 1 hour. Next slide. There are differences between sudden cardiac death, cardiac arrest, and cardiovascular collapse. Sudden cardiac death denotes irreversible cessation of all biological function. Cardiac arrest, effective mechanical function lost. Cardiovascular collapse, effective loss of blood volume or blood flow. Last two are reversible by appropriate measures at appropriate time. This slide shows time references in sudden cardiac death. What are the risk factors? Conventional anatomic screening like calcium scoring, clinical risk factors like diabetes, CKD. It is to be noted that in diabetes, about 1/5 they die of suddenly autonomic dysfunction and multiple etiologies. Risk factors continue, transient risk predictors, inflammatory marker. In inflammatory marker nowadays, they give importance to perivascular adipose tissue measurement in CT angiogram. Personalized risk predictor, familial and genetic. This Framingham study shows deciles of multivariate risk. The number of the risk factors increases, the incidence also increases. In men, the incidence is slightly more than women. This to show atherosclerotic heart disease, how it progresses to acute coronary syndrome module. Like this, sudden cardiac death also progresses through various modules. Pathophysiological epidemiology, subset varied risk, expression varied risk. This is cardiac causes of sudden cardiac death. Coronary artery disease, hypertrophic cardiomyopathy, including any hypertrophy of the heart, myocardial dysfunction, inflammation, infiltration, valve disease, especially severe aortic stenosis, congenital heart disease, especially post-operative cases, electrophysiological problems, sudden death in young and others. This slide shows the usual causes at various age groups from 0 to 30, from 30 to 45, from 45 onwards. What are the usual causes? What are the less common causes? This has been given in this slide. The bottom slide shows incidence according to racial distribution. Black, non-Hispanic shows highest incidence. Physiological epidemiology on power cascade for indicators of risk for sudden cardiac death. Already covered conventional risk factors like Framingham, clinical risk profile, everything we have covered, especially the mechanism-based causes in pathophysiological epidemiology. This slide shows the ejection fraction is indirectly proportional to the incidence. The lesser the ejection fraction, more the incidence of sudden cardiac death. This study conducted in between 15 to 35 years of population in Sweden about sudden cardiac death. Of the roughly about 50% of this sudden cardiac death have only preceding symptoms, all others no symptoms. In non-ischemic cardiomyopathy, NIAHA class 1 and 2, clinically stable. They usually face sudden cardiac death by tachyarrhythmic or non-shockable rhythm. In class 3 to 4, in non-ischemic cardiomyopathy patients, unexplained symptom, syncope, is a powerful predictor of sudden cardiac death. In WPW syndrome, short antegrade refractory pathway, multiple pathway predicts future sudden cardiac risk. In dilated cardiomyopathy, recent meta-analysis inducible and even polymorphic VTVF increases the risk in non-ischemic cardiomyopathy. This slide shows how the coronary spasm provokes arrhythmia and reverse. This is a list of genetic biomarkers associated with sudden cardiac risk. List of genetic biomarkers gets continued. List of protein biomarkers in various disorders associated with cardiovascular disease. Risk of biomarkers associated with cardiovascular disease. This syndrome includes arrhythmic and non-arrhythmic causes. Arrhythmic, ventricular tachycardia, ventricular fibrillation, sudden cardiac death may be preventable, treatable, or terminal manifestation of severe underlying disease. Myocardial infarction and LV dysfunction are the two conditions that have the highest population attribute risk for sudden cardiac death, VTVF, each about more than 30%. Although our understanding of sudden cardiac death due to pulseless electrical activity asystole is growing, the overwhelming majority of research in research stratification is focused on sudden cardiac death due to ventricular tachycardia, ventricular fibrillation. Arrhythmic sudden cardiac death may be due to ventricular tachycardia, ventricular fibrillation, or pulseless electrical activity. Important concepts in risk stratification. The risk of sudden cardiac death, VTVF, is a result of complex interaction of number of factors that results in continuous spectrum of risk. The risk assessment of VTVF must be a dynamic process and will require periodic reassessment. The pathophysiological development of ventricular tachycardia, ventricular fibrillation in presence of LV dysfunction and/or MI can be broadly divided into anatomic, autonomic, and arrhythmia vulnerability. This slide shows summary of the available risk stratification tools. What are the available risk stratification tools in myocardial infarction with or without LV dysfunction? Anatomic substrate, already we have noted. Cardiac imaging, especially SPECT, is more important, and MRI. ECG repolarization, fragmentation of QRS is more important. Autonomic measures, HRT, HRB is among which HRT is more important. ECG repolarization measures, T-wave alterance is more important. Provocative testing, electrophysiological study, ventricular ectopy, and non-sustained DVT and ambulatory ECG monitoring gaining importance. Methods for identifying fixed substrate abnormality already covered. Cardiac imaging, myocardial score, SPECT. ECG measures of depolarization. QRS alone, QRS duration prolongation alone is a questionable predictor, but fragmentation, definite predictor. But the standard definition of fragmentation still not yet delineated. Autonomic function. Of the autonomic function, normal cardiac, mechanical, and electrical function results from balance of sympathetic and parasympathetic tone. The setting of cardiac disease, the balance may be disrupted. Sympathetic excitation can precipitate VTVF, and parasympathetic activation may be protective. Heart rate variability, most extensively studied, investigated, but poor specificity. Heart rate turbulence linked to baroreceptor sensitivity. Measures of ECG repolarization. Even though we measure QT interval more often, the more promising measure of dynamic electrical substrate is microvolt T-wave alternance, that is TWA. This refined study demonstrated that T-wave alterance was an independent predictor of fatal and non-fatal cardiac arrest in patients with recent MI, and its discrimination was enhanced in combination with heart rate turbulence, which is an autonomic measure. So autonomic measure and ECG repolarization both yield still more better results. Cardiac testing and detection of subclinical arrhythmia. Frequent VPC, non-sustained VT are among the earliest established risk factors of sudden cardiac ventricular tachycardia, ventricular fibrillation after MI. Ambulatory ECG monitoring. The utility of ICM may represent considerable advantage over limited ambulatory electrical ECG recording. How to stratify the risk? Current risk stratification is based on assessment of LV ejection fraction. Multivariate, parallel or serial includes all factors. In multivariate, 3A, anatomic, autonomic, and arrhythmic with repolarization, all four. They will derive score based on the score low, moderate, high. Or serial method, multivariate. Autonomic and repolarization, they will take. If it is low risk, they will go for provocative test. In moderate, high risk, they will detect and they will act accordingly. Challenging trials in sudden cardiac death. Determine, parapet, admire, we'll see. At determined trial stopped prematurely. This highlights the challenges in bringing promising risk factors markers to evaluation in randomized trials. Parapet trial, ischemic cardiomyopathy receiving ICD viability with a denervated myocardium is an independent predictor of ventricular tachycardia. Admire HF study, strict assessment of global cardiac sympathetic degeneration, predictor of arrhythmia, non-arrhythmic income in LV dysfunction due to ischemic or non-ischemic etiology. Refine trial, already told. ABCD trial. This shows EP study more useful combination with a non-invasive tool like TWA. ISMA trial, post-MI EF, they have studied with ICM for about 2 years. They found the mortality of 6% annual mortality, but better than limited Holter. Selected important studies of risk stratification for sudden cardiac death, VTVF, in patients with left ventricular dysfunction on myocardial infarction. Due to lack of time, I am moving fast. So overall summation, anatomic, ECG, repolarization and depolarization, risk stratification in left ventricular dysfunction after MI and autonomic. Take-home message. Sudden cardiac death, ventricular tachycardia, ventricular fibrillation, pulseless electrical activity asystole. Overwhelming majority of research has been done only in sudden cardiac death due to ventricular tachycardia or ventricular fibrillation. In myocardial infarction with LV dysfunction, advances in imaging, measures of autonomic dysfunction, measures of repolarization yield promising results. Majority of sudden cardiac death, ventricular tachycardia, ventricular fibrillation without cardiac disease, biomarkers, protein biomarkers, genetic biomarkers, inflammatory biomarkers, and novel imaging technique help us. Serial, multivariate analysis and extensive research, what should be done? Despite this, significant challenges must be overcome. Thank you very much for your patient listening.
Thanks, Professor Dandapani. I think we'll move on to Shanmugha Sundaram's talk on Lord CRT. Please carry on.
Good afternoon, everyone. At the outset, I'd like to thank TNEPIC for giving me this opportunity. For the next 10 to 12 minutes, I'll be discussing about the evidences which is there for conduction system pacing as an alternative for cardiac resynchronization therapy. We know that fibers inside the histamine is long-termly dissociated. There will be predestined fibers which can go either into a left bundle or right bundle. So if there is any segmental disease in these fibers, the ECG will show either left bundle patch block or right bundle patch block. So by doing a his-bundle pacing, if you are going to bypass that disease segment, for example, if the disease is here and you're going to pace the lead distally, you'll be able to narrow down the QRS, you'll be able to improve the synchronized contraction of the ventricles. Ultimately, it will improve the LV contractility and LV ejection fraction. So for example, in this patient where there was a baseline left bundle branch block morphology with a QRS duration of 160 milliseconds, the electrophysiology study showed a HV interval of close to 88 milliseconds. So what we did was we just scanned the his bundle to look for a normal HV interval zone. So that means that we have bypassed the disease segment. You can see the pacing leads HV interval, which is almost near normal. So once you place lead in the normal HV interval area, you'll be able to regenerate a normal appearing QRS. So needless to say, once you narrow down the QRS to a normal duration, then the patient's ejection fraction will be improved. Similarly, in patients with a right bundle branch block, where there may be an intra-his disease within the his bundle, if you're going to bypass the disease segment, you'll be able to narrow down the QRS and you'll be able to see a visible improvement in LV ejection fraction. So this particular echoes were taken at an interval of 10 days. So this was a pre-procedure echo where you can see a poor LV contractility with an LV clot. This is post-procedure after 10 days. We can see a brisk contraction, improvement in LV ejection fraction, and dissolution of LV clot. So what the guidelines say? The latest guidelines published by European Society of Cardiology, they have clearly showed that HBP can be considered as an alternative for cardiac increase precision therapy. But they've mentioned that in patients with left bundle branch block, classical LVBP, and an ideal CRT candidate, still BIV pacing has more solid evidence, and therefore it remains the first-line therapy. And HBP can be considered as a bailout solution in those patients where you can expect a poor results from from CRT by BIV therapy, for example, an RBB patient, or in those patients where there is an incomplete reduction in the QRS duration, where you can use the his bundle pacing as an optimized resynchronization therapy. Of course, in patients where there is a committed ventricular pacing and LVEF is very low, where you can expect the RV pacing to worsen the LV function, you can use his bundle pacing as an alternative, as a class 2B evidence. And in those patients where there is a poor CS anatomy, HPP can be considered as a class 2 evidence for doing a cardiac resynchronization therapy. What about left bundle branch pacing? We know that left bundle branch pacing overcomes many of the limitations of his bundle pacing. Here, the lead will be deployed in the proximal interventricular septum below the his bundle to capture the broad fan of LVP fibers on the LV subendocardium. There are certain areas where CRT by LVBP can be as good as a BIV therapy. For example, in these patients where there is a non-ischemic cardiomyopathy with a white QRS and LV morphology. So we know that in left bundle branch block, that this is predominantly will be in the intra-hisian segment of the his bundle, almost 60 to 65% of the patient. And in remaining 20 to 25% of the patient, the disease may be in the proximal left bundle. So almost 90 to 95% of a non-ischemic cardiomyopathy with an LVBP can be corrected by doing a proximal left bundle branch pacing. If you're going to adjust the AV delay, if you're going to adjust the output, you'll be able to further narrow down the QRS by additional 10 milliseconds so that the patient can achieve a maximum resynchronization therapy. Remember, here we are using a dual chamber pacemaker, not a conventional double chamber CRT device. So these are the results from the International Olympic Collaborative Group where we are a part of the study. So this was presented as a late-breaking clinical trial in HRS 2020 and later published in JACC-EP 2021. So in this particular study, we have demonstrated that left bundle branch pacing can be utilized as an effective alternative to cardiac resynchronization therapy in patients with a white QRS. So we have analyzed the patients with an ischemic and non-ischemic, with an LVB and non-LVB morphology, where we could show that both patients with an ischemic cardiomyopathy and non-ischemic cardiomyopathy, and both patients with a baseline LVB morphology and non-LVB morphology showed good improvement in LV ejection fraction, NYHA functional class, and good reduction in LV and diastolic diameter. Subsequently, Dr. Huang, who is considered as a father of left bundle pacing, has demonstrated that in patients with a non-ischemic cardiomyopathy, and if you're going to do a perfect left bundle branch pacing, at the end of 12 months, the patient will have a significant improvement in LV ejection fraction. And you can see here, almost 57% of the patient had a normalization of the LV function at the end of 6 months, and almost 75% of the patient had normalization of the LV ejection fraction at the end of 12 months. This happens rarely with CRT by BIV therapy, though we have not done direct head-to-head comparison, but I can assure you that the normalization of the LV function, 75% of the patient or 75% of the included patients in the included cohort showing a normalization of the LV function is a huge number for a cardiac resynchronization therapy. Subsequently, we have demonstrated a specific subset of patients with an LBBB. So if you follow the patients with a baseline LBBBs, there are some patients who can worsen, there are some patients who can have a normal LV function for a long duration of time. So what we did was we have taken all the patients with the left bundle branch block associated cardiomyopathy, and we have specifically looked for this entirety LBBB-induced cardiomyopathy. So we have defined LBBB-induced cardiomyopathy as those patients who had a baseline LV normal LV function when LBBB was diagnosed, and over a period of next 2 to 3 years, they had worsening of LV function. So when we did left bundle branch pacing, almost there was a 34% reduction in QRS duration, and we could show that all patients were super responders or hyper responders. They have normalization of LV function at the end of 6 months. So this specific subset of patient, LVBB-induced cardiomyopathy, if you're going to do a left bundle branch pacing with a simple dual chamber pacemaker, you'll be able to show a hyper response in almost all patients. So these are the previous group of patients which we have discussed where the left bundle branch pacing works as good as bi-V therapy. There are certain scenarios where left bundle branch pacing can be better than conventional bi-V therapy. So we know that patients with a baseline RBBB are poor responders to CRT. We know that patients with abnormal baseline QRS axis are poor responders of CRT, and a baseline IVCD are again poor responders of CRT. In patients with an RBBB, a wide QRS, and non-ischemic DCM, we'll be able to narrow down the QRS to almost a near normal value if you're going to do a perfect left bundle branch pacing. So in this patient, DCM RBBB, male patient, a non-ischemic EF of 30%, once we did a left bundle branch pacing, once we reduced the QRS duration, once we produced a rapid left ventricular activation by having an LVAT of less than 70 milliseconds, we could show that the EF in this patient could be improved from a baseline of 30% to almost 55%. So this is our data, which is an unpublished data. So what we have analyzed was we have just taken out the patients with the baseline RBB morphology. So out of 260 patients which we have done in our institute, almost 60 patients had a baseline RBB morphology. So we could reduce the QRS duration from 143 milliseconds to 130 milliseconds. The peak left ventricular activation time was 68 plus minus 10 milliseconds. And the baseline LV ejection fraction, which was 55 to begin with, remained as 56 at the end of close to 2 years follow-up. We have analyzed the patients with the baseline LV dysfunction. So out of 60 patients with the baseline RBB morphology, 14 had a baseline LV dysfunction, which would be defined as an EF of less than 50%. So what we could show was by doing a left bundle branch pacing, the QRS duration could be reduced from 153 milliseconds to 118 milliseconds, and the baseline LV EF of 36% have improved to 56% at the end of 2 years follow-up. We could also show that there is a good remodeling of left ventricle. So the baseline LV and diastolic diameter of 56 millimeter could be reduced to 53 millimeter. Of course, the fluoro time will be a little bit longer in patients with an RBBB because we expect a poor anatomy, a little bit dilated ventricle in patients with an RBBB and LV dysfunction. Needless to say, in any patients, any subgroup of patients with the undergoing left bundle branch pacing, the pacing threshold remains stable. So this is the one which will be published soon. So this is again an international LBB collaborative group where we had analyzed the data of patients who are recurring CRT with the baseline RBB morphology. I'm not going to discuss about the results of the study because it will be published soon in a major journal. Of course, this is going to change probably the practice of doing a cardiac resynthesis therapy in patients with the baseline RBB morphology. The second subset of patients, baseline abnormal QRS axis. So what we did was we have analyzed the patient with a non-ischemic cardiomyopathy in LBBB, and we could see that almost 63% of the patient had a normal axis and 37% had a left axis. So among the patients with a normal axis, after doing left bundle branch pacing, 93% had retained their normal axis and 7% had a left axis deviation after doing LBBB. In patients with an abnormal axis, we could show that 75% of the time we could correct the abnormal axis to a normal axis, and in the remaining 25%, the left axis remained after doing left bundle branch pacing. But what interesting thing we could observe was, whatever be the normal baseline axis, whether it is a normal axis or a abnormal axis, irrespective of the underlying axis, we could show that left bundle branch pacing resulted in reduction in QRS duration. Left bundle branch pacing resulted in increase in LV ejection fraction. And we could see that the LV and diastolic diameter also has come down during follow-up in both patients with an abnormal axis and a normal axis. There's a patient with an abnormal axis where you can see here the baseline left bundle branch block with the left axis could be corrected to a normal appearing QRS with a normal axis after doing left bundle branch pacing. The hypothesis which we have put for the baseline left axis deviation, which is very difficult to explain, was since we are directly pacing the left bundle, the most important cause could be an associated left antivesicular block. Since you are going to pace the lead in the proximal LVVV, you may be able to simultaneously pace the left anterior vesicular block so that there will be a normalization of the QRS axis. So the major findings of our study, which is going to publish in JC, so this was the baseline abnormal axis was observed in 37% of the patient, and the left bundle branch pacing resulted in retained the axis in 93% of the patient and normalized the abnormal left axis in 75% of the patient. And the important thing, left axis deviation was not associated with unfavorable outcome after CRT by left bundle branch pacing. Remember, whatever trials you're going to take in a patient with an abnormal QRS axis with a cardiomyopathy, with an LVBP, the patients were considered as a poor responders to CRT by IV therapy. Of course, there are certain segment of the patients where you will not be able to narrow down the QRS completely by doing left bundle branch pacing alone, because there may be associated defects in the peripheral conduction system, or there may be an IVCD where you may have to go for a left bundle branch optimized CRT. For example, in this patient where there was a baseline in LVBP, despite multiple attempts, we could not narrow down the QRS completely by doing a left bundle branch pacing. So obviously, we had to put one more lead in the coronary sinus to achieve a left bundle branch optimized cardiac resynchronization therapy. You can see a near normalization of the QRS once both left bundle branch pacing lead and the CS lead was utilized. There's again a late-breaking clinical trial which was presented in this recent HRS and later subsequently published in Health 2021, where we could show that this left bundle branch optimized CRTs, at least in patients whom the LVVP alone could not narrow down the QRS, has shown better results as compared to a BIV CRT. There are certain acute benefits which we could see visibly in patients who are undergoing conduction system pacing, and which is rarely seen in patients undergoing cardiac resynchronization therapy by BIV device. So this immediate improvement. So immediate improvement classically seen in patients undergoing either Eastman or left bundle branch pacing. For example, this patient with the baseline LVVP and white QRS presented with heart failure stabilized, and you can see within a period of 7 days, the LV contractility improved, the pericardial effusion, which was there before the procedure, got settled, and the patient had a significant improvement in LV ejection fraction. Of course, mechanical problem, mitral regurgitation, you can see this echo was taken over a period of 10 days, where you can show that, where you can see that the baseline, almost moderate to severe mitral regurgitation, has come down to probably grade 1 or grade 2 mitral regurgitation after the procedure. Similarly, electrical resynchronization, you can see the baseline dysynchronous contraction has resulted in better synchronized activation of the ventricle. So this will be translated effectively as better LV contractility, improvement in LV ejection fraction, reduction in VHA functional class. So these effects, though, can be seen in CRT. Those acute benefits are very rarely observed in CRT by IV therapy, but it is very well seen in patients who are undergoing CRT by left bundle branch pacing. Another major advantage of doing a cardiac resynchronization by therapy by left bundle branch pacing is this conduction system pacing will allow us to use any number of leads. We can do a CRT by doing a single lead, using a single lead. For example, the first case was an atrial fibrillation with an LVVV, which is a very rare combination with a significant LV ejection fraction, significant LV dysfunction. This particular lady had an LV ejection fraction of 28% to begin with. So we have ablated the AV node. Basically, we targeted the AV node to allow for a junctional escape. And post-ablation, we just placed the lead in the left bundle branch area where we could narrow down the QRS. And within a period of 1 month, her ejection fraction has jumped from 30% to 45%. Of course, this is what we are doing now, a dual chamber pacemaker for a non-ischemic DCM with an LVBP. Suppose if the LVB is not getting narrowed down with a conventional dual chamber pacemaker, then obviously you can go for a triple chamber conventional CRT device. And in those patients with an ischemic DCM or an associated IVCD where you will not be able to narrow down the QRS with an left bundle lead alone, you can use a quadruple lead to complete a CRTD device. Word of caution. Though I've discussed a lot about the left bundle branch pacing positive aspects. Remember, there's a new procedure which was started in 2017. There's no long-term data available. Recently published data gives only a 3 years follow-up. And this pacing lead 3830 select secure lead is primarily not meant for deep septal pacing. And still the data is awaited regarding the myocardial contraction induced lead damage, insulation damage, and other thing. Of course, there are potential complications which you have to keep in mind while doing the procedure. There are instances of lead dislodgement. I had a patient where the lead got there was a micro dislodgement after 2 years. I had to extract the lead and put the lead in again in the same area. Of course, once the lead penetrates into the LV, there are risk of thromboembolism that you have to keep in mind and follow up the patient for potential thromboembolic complications. And there are no long-term data on lead extraction. There are occasional case reports, 1 year extraction, 1 year lead extractor, 2 years lead extractor, but still long-term lead deep inside the septum, where we don't know whether we'll be able to extract the lead completely after probably 7 or 10 years. What guidelines is this is what matters now. Of course, the recently published European Society of Cardiology guidelines have stated that the advantages of this technique are excellent, and this effectively overcomes many of the limitations of Heisman spacing. But the data is very scarce. The data on safety aspects and the randomized control trial, all these are not available as of now. So what they've stated that as of now, they're not going to recommend double band spacing as a therapy for as an alternative for cardiac resuscitation therapy. But they've stated that, however, conduction system pacing includes HPP and double bunch area pacing is very likely to play a growing role in the future. And the current recommendation will probably need to be revised once more solid evidence for safety and efficacy is published. So this is what we are doing. We are generating more and more evidence to show that this conduction system pacing works well in patients with ischemic and non-ischemic cardiomyopathy. And once sufficient evidence is generated, this will probably go up in the guidelines to have a class 1 indication. Thank you very much for your patience. Thank you.
Thanks, Shanmugasundaram. As ever, pleasure listening to you. We'll move on to Dr. Lawrence's talk and have the discussion towards the end. How do we improve the heart failure outcomes from CRT, which is well established now? Over to Lawrence's talk, please.
Hello. Hi. Hi, everyone. My sincere thanks to Dr. Jaishankar and the organizing team of TNEPIC for giving me this excellent chance to be among with you. My topic for discussion today would be on improving heart failure outcomes with CRT. We all know close to 1/3 of the patient with class 1 indications for CRT are non-responders. This comes across all the trials which have been done on CRT. The defining non-responders in CRT also be somewhat cumbersome or difficult because every trial used different parameters. Some of them used clinical response like change in functional class, while some of the studies and trials used improvement in LV ejection fraction or end systolic and end diastolic volumes as a marker. So whatever may be the term they used for identifying the non-responders, we always had a significant number of patients who had a class 1 indications for CRT have not responded. We also know that close to 20 to 25% of the patients in most of the trials were super responders. That is, they respond better than what we expect. Some of the patients have a nearly near normal return to ejection fraction, which we see in our clinical practice also. Not only identifying a non-responder, identifying a super responder also may be useful to talk to the patient about the response to the therapy. Agreement is poor among current criteria which use for defining response to CRT. Some of them use absolute increase in ejection fractions. Some of them use change from a baseline. Some of them use volumes more. But whatever may be the case, I think most of us know how to see the improvement in the patients who had implanted with the CRT. Whatever the parameters we use, even on the patients who have been class 1, the response rate ranges between 70 to 80%. So the most of the older trials had a non-selective response of around 70%. Close to 2/3 of the patients respond across large trials which have been done on CRTs. Response to CRT, we know, not only depends on the patient, not only depends on the physician. There are multiple parameters which are involved, which are ultimately going to decide a response to a patient to a CRT. The most important clinical factors which influence response to CRT, as we know, the highest response comes from wider the QRS, left bundle branch block pattern, and non-ischemic cardiomyopathy, particularly in female patients. This is the group which responds extremely good. While males with ischemic cardiomyopathy, they do not that great. And we know very well that the response is lowest in patients who have a narrower QRS. I'm not talking about narrow QRS. narrower QRS, and non-left bundle branch block patterns. There are few of these parameters which ultimately decides non-responders, which can be corrected. Like you have a suboptimal AV timing on your CRT or suboptimal LV lead position. There is sometimes it's correctable if you are able to spend another few minutes in selecting a proper way, can be corrected, and identifying the causes for suboptimal biventricular pacing, like atrial fibrillation or multiple ventricular ectopics, which is not allowing you to deliver 100% biventricular pacing. The primary challenge in managing patients with CRT remains all this: getting a proper vein, getting a good AV and VV timing cycles. Getting a good vein is very important, but what is a good vein? That's very difficult to identify when you are doing a CRT, because some patients, even though the ECG may look alike, all the ECG may look like left bundle branch block pattern, the vein which has the latest activation has to be selected. In this example, you can see the same left bundle branch block pattern. One patient has an anterolateral vein as the latest point, while one patient has a posterior vein as the latest part, and some patient can have a very basal part of the veins as a later part. You have to identify the region. Now we know very well by looking at the QLV, if you have a QLV which is larger than 100, 120, you are in the latest part of the vein. I think if you have 2-3 veins, selecting a proper vein is more important. I always say whenever I talk on CRTs to colleagues and juniors, when you start doing a CRT, the most important thing is not putting the LV lead, but most important thing is putting a LV lead in a proper vein. Just putting a LV lead will not help you or the patient. You have to select the proper vein. Sometimes you may see that the vein which is easier may not be the correct vein. So you have to select a vein which is going to give the better results. We know very well from the multiple studies earlier how to identify the proper vein. And we know very well also the left bundle, all the left bundles are not same. You need a left bundle which is going to cause a significant delay in the left side, then only your patient is going to improve. If you're not going to have a left bundle which is wide enough, which is not having a significant delay in the posterolateral or lateral part of the left ventricle, then if you're going to put a vein lead there, it's not going to help you much. So we know very well that more than anything else, selection of the case is very important. If you are going to select the proper cases, like you select a patient with a significant intraventricular delay identified by a wide left bundle branch block pattern in a non-ischemic cardiomyopathy, you are going to have a better outcome most of the times. The higher outcomes always remains in left bundle branch block pattern when they have QRS more than 150 milliseconds in females. Non-ischemic cardiomyopathy who have a documented mechanical dysynchrony, smaller LA volumes, smaller endostolic volumes with a reduced scar burden identified with the MRI, and LV lead not in the scar. That's very important. When you have a patient who has ischemic cardiomyopathy particularly and have a circumflex territory infarct, first I always do a cardiac MR to see that the OM territory which you are going to select is not scarred. Otherwise, going in and putting a lead on a scarred area is not going to help you, because sometimes you may get a good thresholds also if you're able to pass the scar with your lead. But sometimes because you are scarred in the middle of ventricular activation, your activation from the left ventricle may not reach at the time when you are expecting it to reach. So is the CRT response is improving? What you saw 70% is improving. Definitely we know that it has improved because of better patient selection. You have selected patients with the left bundle with no lateral scar. You have been be attentive to optimal lead positioning, like putting the lead in the basal and middle V region, and quadripolar lead technology, which is a big leap which happened in the CRT technology, is a quadripolar lead, which made you to put the vein with a good stability, getting a good stability without compromising a good lead position. So it has allowed us to get a good management of PNS also, which was a problem earlier days, and it achieved a good stability. You have a good therapeutic options. Now you have the problem with the earlier bipolar leads is you have one vein, you go in, put it deep, and you see there is a PNS, you cannot pull it because you will affect the stability. Now you have a quadripolar lead, go deep in, get a stable position. After that, you have multiple choices. You can select a lot of basal positions from where you can pace, although your lead has reached apical position. And optimal programming is more important part of your device selection. And one of the problem with the device, what you say, that AV timing cycles programming was echo-based timings were not very dynamic. you select a patient for a echo-based AV timing cycles, and the patient walks around, increases the heart rate. The program, whatever programming you have done, may not be appropriate. Now we have most of the devices have inbuilt algorithms by which they can select the better AV timings. And you have multiple optimization algorithms available in each company, like QuickOpt, SyncAV, and you have a surrogate LV, QLV measurements available in most of the CRTs. All the high-end devices now have excellent algorithms which you just switch it on that take care of the AV timing cycles in a better way. So how we are going to respond, how we are troubleshoot a non-responder. When you identify non-responder, most important thing is you have to see that have you ticked all the boxes which have to be there in any patients with heart failure. All the medications are optimized. If the lead is in an optimal position, are you activating the latest position? Are there any other comorbidities like anemia, renal failure, or AFib which has care on its own? Is the patient has a significant biventricular pacing of more than 90%, and if you are able to achieve more than 95%, it's better for you. And if your device has optimization algorithms available, have you optimally utilized them? So implant issues, what you have to look at is the lead is optimal lead position is not possible. You have to, as I told you, most of the time it's possible nowadays to with the quadripolar technology. You can select a lead position which is optimal without much of a threshold value. Sometimes you may have to choose a place where you have a higher threshold, even though the other place can have a lesser threshold. But if you feel this position is better for the CRT optimization, then you have to put there only. And you have to identify true non-responders. That's very important. So most of the times, a quadripolar technology has helped in putting you in a better position. So apical placement, we know, does not help you, although your lead may be stable. And a lot of times, going apical with a lead has not helped you, but that gives you an excellent stability. With the quadripolar technology, what you have achieved is you have gone in, you see this lead in an excellent vein. It looks like a very good vein for optimization, but your lead has reached very laterally, and these kind of very lateral and apical positions may not help you to achieve a CRT optimization if it is a bipolar lead. But at the same time, if you're able to position this lead in that place, it will affect the stability. But if you have a quadripolar lead in, you can achieve both stability and good basal positions. So post-implant, another important thing, you put a quadripolar in a good position, you still have to optimize the CRT to get a good response. If we have one of the common reason why a patient has to be a non-responder for a CRT was timing cycles are not optimal. And the problem, already I told you, you cannot optimally program your device just at the static state at echocardiogram. So most of the time, what we have to do is a lot of these algorithms are useful. If you switched on the algorithms and make sure that these algorithms are on, you can optimize this AV timing cycle without doing a repeated echocardiogram to time the cycles. So now we have enough data from most of these trials that switching on these algorithms helps you in optimizing this AV timing cycles and delivering a good dynamic AV interval adjustments and ultimately leading to a better response. One of that kind of an algorithm is an adaptive CRT, which is available in about devices, and it just look at your native rhythm. It looks at how your RV and LV conduction times are, and optimally adjust the timing cycles so that you are able to deliver a proper good CRT at a cycle lengths which are suitable for achieving a good fusion, so that you have a midline fusion, your LV and RV fusing is proper so that you achieve a good CRT response. So you have another algorithm coming from an Abbott, which calls it a SyncAV. You have multiple algorithms available in most of these devices, which ideally they are going to dynamically adjust your AV, VV timing cycles so that you are going to achieve a good CRT response. This is a big improvement, I would say, that because now we know not every CRT is implanted by experienced CRT implanters, and they may not have a time to program the device, or they don't do programming these devices timing cycles properly. But having these inbuilt algorithms definitely help most of these patients by switching it on. So what you can do is, whenever you have a patient with a CRT, switch on most of these algorithms. And if even on these algorithms, patient remains non-responder, then you can take the patient for an echo-guided optimization. So this is what I was telling. The newer AV optimization techniques and algorithms have significantly reduced non-responders because of this region. And multi-point pacing is another one thing which is available in a lot of devices now. You can, because you have 4 poles here, you can pace from two of that pass at a simultaneous time to achieve a multi-point pacing. Just look at this algorithm. Patient had a spontaneous QRS of 168 milliseconds. At BIV, it was a significant drop, 108 milliseconds. But when they switched on multi-point pacing, it has dropped to 74 milliseconds. So this is going to give an excellent response to the patient. So with the multi-point pacing, they were able to achieve at a close to 44% reduction in the non-responder rates. So what I usually do, most of my patients, when they are non-responders, I switch on a multi-point pacing. Not every patient who have a multi-point machine, I switch it on multi-point pacing to start with. I usually allow the patient to be on a usual BIV pacing. When the patient comes back with a non-responder rate, so I usually switch on the BIV pacing. We know very well that one of the other reason why a lot of patients, they don't respond is AFib. The proper control of AFib, either the drugs or in some patients, if we have to achieve, may require AV nodal ablation to achieve a good BIV response. So how we are going to optimize CRTs? You have to do a BIV pacing 100% as much as possible. You have to program the AV interval in a proper way. How we are going to eliminate the residual LV dysynchrony? You can use, and most of the time we are using a LV lead, which is quadripolar, and you can use multi-point pacing. And there are a lot of algorithms available which can help you to improve the response rate. So if the patient has a AFib, try to maintain cyanoism. Not possible, try to bring down the rate by using a AV nodal drug. If not possible, you can consider doing a AV nodal ablation also. Thank you. Thank you for wonderful hearing.
Thank you very much, Dr. Lawrence. And then we move on to the next talk on patients of right middle branch block with LV dysfunction. Is there any hope for them? Professor Ajay Naik will be delivering the talk on this. Over to his slides, please.
Can we also get a link for the
Thank you, Dr. Jaishankar, for giving an opportunity to present in this excellent meeting. I'll be speaking on, is there hope for patients with RBBB and LV dysfunction? We have been implanting CRTs in heart failure patients for more than 2 decades, and the benefit is intuitively obvious when we are dealing with LBBB patients. In fact, the majority of patients enrolled in CRTs had LBBB configuration. The pathophysiology of abnormal ventricular activation has been well studied in the setting of LBBB, which results in delayed contraction of the lateral free wall. Simplistically, atrial-based biventricular and left-sided pacing in patients with LBBB may coordinate the dysynchronous ventricular contraction and reduce the MR. But in reality, it's a complex interplay of intraventricular and interventricular remodeling, papillary muscle contraction and resynchronization, and optimization of the left-sided AV contraction. In presence of RBBB with intact left bundle conduction, the addition of a single pacing side on the left side may not be expected to result in obvious benefit. In fact, even in the companion study, patients were randomized to CRTP, CRTD, OMT. Patients with LBBB had the best response in terms of all-cause mortality and hospitalization. Patients with RBBB and IVCD, they were pooled together. They did not show as much benefit with CRT. One of the earliest studies in patients with RBBB heart failure was by Garrig, 12 patients, QRS duration more than 140, and RBBB achieved benefit from CRT, but only when RBBB was associated with major left intraventricular dyssynchrony as detected on echo. An electroanatomic mapping study found conduction delay in both bundles. There are pathophysiological reasons to expect a response to CRT in at least some patients with RBBB and cardiomyopathy. Delayed LV endocardial activation was seen in most patients with RBBB and left axis deviation. And these patients are the ones we generally target when we think of implanting CRT in RBBB patients. In fact, echo studies have shown evidence of significant LV intraventricular mechanical dysynchrony in patients with RBBB. One of the first systematic reviews from RCTs of CRT on the outcomes of patients with baseline RBBB was by Pablo Neri. 4 publications, 5 RCTs, but the number of patients is limited. It's just 485 patients. None of the available data suggests more favorable outcomes with CRT in these patients. There was insufficient detail in the publications to enable a formal meta-analysis, and a number of studies like Companion or Reverse presented RBB patients in the same subset as non-specific IVCD, so they could not be included. In fact, in the major studies, the number of RBBP patients has ranged from 4.3 to 12.5%. And when we look at the effect of CRT in patients with RBBP, the major studies, CARE-HF, MADIT-CRT, RAFT, have not shown major positive effects. In fact, the effect was neutral. The positive results were seen in Miracle and Contact CD trial. NYHA class change favorable for CRT, and other parameters were neutral. Dr. Behzad Pauri had published the CRT in patients with RBBB analysis of pooled data from the Miracle and Contact CD trials, which had shown the positive response. Total 61 patients with RBBB were identified. 34 were randomized to CRT group, 27 to control group. The data from these patients were entered into a new database and analyzed. And in these patients, CRT was found to improve NYHA class compared to control. So NYHA class improved from 3.1 to 2.3. Improvement was also seen in the no CRT group, so medical care must have been excellent. There was trend towards improvement in 6-minute walk distance, some improvement in LV function, but not significant. In fact, in the CARE-HF study, RBBB at baseline was a predictor of adverse outcome. And even in the MADIT-CRT study, patients with LBBB were found to improve much better. They had much better outcome. RBBB patient, it was not seen. Looking at the 15,000 Medicare registry patients with CRTD, median follow-up of 40 months, Ken Bilchik had published this. Patients with advanced heart failure, elderly patients obviously had increased mortality after CRTD, but RBBB patients had worse outcome, and especially those patients who had ischemic cardiomyopathy or a combination of two were the highest predictors of mortality. Looking at this data, this is patients with LBBB, freedom from death. Patients with LBBB fared the best. IVCD was intermediate. Patients with RBBB had the worst outcome. And looking at heart failure, hospitalization, or death, again, LBBB patients fared the best, IVCD intermittent, and RBBB patients had the worst outcome. The mortality rates over 1, 2, and 3 years consistently showed that patients with right bundle branch block, whether non-ischemic or ischemic, they had the worst outcomes compared to patients with LBBB. Same thing is shown here in the tabulated form. Patients with RBBB had much worse outcome compared to LBBB. IVCD was intermediate. So when we look at RBBB LV dysfunction, is CRT the right way to go? Masked LBBB may be present in significant proportion of patients identified as having RBBB. Small number of RBBB patients in RCTs preclude definitive conclusion about efficacy of CRT in these patients. So at present, there is insufficient evidence to withhold therapy from this group. And that's why in 2021 ESC guidelines on CRT, apart from the routine indications of LVBB, QRS more than 150 or 130 to 149, when you look at patients with non-LVBB QRS morphology, with QRS duration more than 150, this is a class 2A indication. Patients with QRS duration 130 to 149 milliseconds, non-LBBB QRS morphology. It's a 2B indication for CRT. So what we really need is a meta-analysis of RBBP patients from the major CRT trials. Analysis should look at the hard and soft outcomes, examine the subsets within the right bundle branch block population, including etiology of the underlying disease, presence of left fascicular block, presence of LV conduction delay in some form. Trials to enroll patients with RBBP and CHF using other indices of dysynchrony like LV strain, or more mechanistic studies are required for resynchronization of RV with multiple RV leads or alternative RV or LV side lead positioning. And in fact, that is the exciting part that we are coming to in the last 2-3 years. In the enhanced CRT trial, this is CRT implant strategy using the longest electrical delay for non-LBBP patients. It randomized 248 patients with non-LBBP pattern and CRT indication in 2:1 fashion. One was QLV based LV lead implant versus standard of care anatomic LV lead implant. Majority of patients had RBBP, more than half of the patients had QRS width of more than 150 milliseconds. The study showed a 70% response rate, improvement in composite clinical score to CRT in all comers, no significant difference between RBBP and the IVCD group. This is exciting and very landmark study, permanent His bundle pacing for CRT in patients with heart failure and RBBP. So Parikshit Sharma and Dr. Vijay Raman have published this. His bundle pacing was done in 39 patients, heart failure, RBBP. The implant was successful in 37 of 39 patients, overall success rate of 95%. Patients were followed up for a median of 15 months, 3 patients lost to follow-up. The QRS duration decreased significantly from 158 to 127 milliseconds. And patients with underlying ventricular pacing, also the QRS duration, the pace QRS decreased from 198 to 141 milliseconds. So significant improvement in QRS morphology. In fact, on vector cardiology, this is the patient with right bundle branch block delayed RV activation after non-selective His bundle pacing with RBBP recruitment. The delay in RV activation has been negated. On echo, which was defined as more than 5% improvement in LVF was considered as a positive response. It was noted in more than 2/3 of the patients. Overall EF improved significantly from 31 at baseline to 39% at follow-up. And in patients with more severe LV dysfunction, EF less than 35, EF improved significantly from 26 to 34%. This is the same seen much better synchrony in the various segments after non-selective His bundle pacing compared to the baseline. So just summarizing, this is His bundle pacing in RBBP, Dr. Parikshit Sharma and Vijay Raman's publication, 39 patients, successful implant in 37 of those 39, QR's duration improved, LV function improved, and NYHA class improved in these patients. So NYHA class improved from 2.8 to 2 in these patients with who underwent non-selective His bundle pacing. On electroanatomic mapping, this is patients with intrinsic right bundle branch block. LV activation is homogeneous, but RV activation is delayed. After non-selective His bundle pacing, LV activation is preserved as before, but the RV activation is much better, activated basal onwards, and the delay in RV activation has been negated. So His bundle pacing in right bundle branch block with heart failure, this is a exciting new vista. In this study, the main findings were that in patients with cardiomyopathy, reduced LV function, RBBP, heart failure, permanent His bundle pacing resulted in significant reduction in QRS duration when applied to patients with RBBP and LV impairment. and significant improvement in LV function and NYHA functional class were observed when his bundle pacing was applied to this population. So overall, looking at this entire scenario, are we right in doing a conventional CRT in RBBB LV dysfunction patients? This entire concept needs a critical relook. We need to study these patients a little more in detail. Permanent his bundle pacing was feasible with high success rates in patients with RBBB and indication for CRT. His bundle pacing was associated with significant narrowing of the QRS duration, improvement in LV function. So his bundle pacing may be a reasonable alternative for patients with LV impairment and right bundle branch block. Of course, the other form of conduction system pacing, left bundle branch pacing, will also need to be studied because a lot of people are graduating from his bundle to left bundle branch pacing, and majority of implants nowadays are left bundle branch pacing. So this needs to be studied also in this population, whether his bundle gives better results, or can we do left bundle pacing, or there is some other form of conduction system pacing that needs to be explored. So future randomized studies are essential to understand the role of his bundle pacing, conduction system pacing compared with BIV pacing or no pacing in this patient population of RBBP and LV dysfunction. Thank you very much, and I will be happy to take any questions. I'm sure this will encourage a very stimulated discussion. Thank you.
Thank you, sir. Very nice presentation. Would request you to stay on for the last talk, and then we'll take the questions. I'll invite Dr. Jayapandian to talk on pacing-induced cardiomyopathy, and we'll have the discussion soon thereafter.
Good evening. I'm Dr. Jayapandian, consultant cardiologist and electrophysiologist, Meenachi Mission, Madurai. So I give a sincere thanks to my mentor and my teacher, Jay Shankar sir, giving this opportunity. Today my topic is pacing-induced cardiomyopathy. So after 60 years of cardiac pacing, in our conventional cardiac pacing have effective for preventing of syncope due to bradycardia, that is a variant type, either from sinus tachycardia, sick sinus syndrome, AV blocks, and complete heart block. And sometimes they may need a AFib for AV nodal ablation for pacings. There are a lot of indication for pacing indication for last 2 decades. And also it can prevent from death due to asystole. But the main problem is here, after chronic LV RV pacing, it will leads to some percentage of patient, but we don't have a proper documentation or long-standing studies which shows LV dysfunction and risk developing for AFib and heart failure and hospitalization and mortality. So pacemaker-induced cardiomyopathy is a chronic RV pacing leads to LV dysfunction, which depends on the variable factors like variable duration. The duration means there is most of the patient it may develop the LV dysfunction either in the less form or higher form. But in my experience, for 2 to 3 patients after implanting started pacing, patient developed LV dysfunction within a week, and but most of the time it may not. And second point is anatomical site of pacing depends on the site, but that various studies I am going to discuss in the later slides. Various studies shows non-apical pacing versus apical pacing. Nothing shows much difference in the mortality and outcome LV dysfunction. And pre-implant LV function also very important. And QRS duration and pre and post implant also very important. Post implant QRS duration is very high. That's also it leads to LV dysfunction. And burden of pacing, it's a number of percentage of pacing also is very important here to deciding factor. So, pacemaker-induced frequency and risk factor, we will discuss about the pathophysiology of the cardiomyopathy. Once we implanted, patient developed for RV apical pacing, electrical dysynchrony, which leads to mechanical dysynchrony. That is, I am going to discuss one by one. Once the electrical dysynchrony develop, it's aberrant conduction like left bundle pacing, left bundle branch block like mechanical dysynchrony only, and that lot of risk factor which also increasing the pacemaker induced cardiomyopathy like male sex and wider QRS, and even though wider native QRS and lower baseline ejection fraction and percentage of pacing, this and all leads to pacemaker induced cardiomyopathy. Overall, all studies and after meta-analysis, it shows around 10 to 20% of patient may develop LV dysfunction. Either it may be a lower one or higher LV dysfunctions. So, as I told previously, it's an immediate decline of EF in the RV pacing is a possible. That in this studies you can see that from baseline to after a few weeks and month, it can reduce from all form. First, it will develop diastolic dysfunction followed by the systolic dysfunction. So, spectrum of risk factor and development of PIZM or the spectrum of potential manifestation in pacing induced cardiomyopathy is a 3 years follow up from drop of LV dysfunction from normal to less than 50%, but patient may be asymptomatic, and drop LVEF from the baseline, but still more than 50% is the most of the patient presents like in our practice. And worsening pre-existing cardiomyopathy, for example, previously 40% EF, it will may worsen after RV pacing and depends on the percentage of pacing also. Then next spectrum will be patient developed heart failure symptom and hospitalization and atrial fibrillation. It leads to abnormal myocardial function without symptoms. There is some patients drop in LVEF, but there may not be a symptom that we are seeing in our clinical practice, and increasing natriuretic peptide also. Then come to the risk factor, as we discussed about increased risk of pacemaker induced cardiomyopathy in older age group is very high, and male gender and wide QRS, broad based QRS and baseline and native also, and presence of atrial fibrillation or development of atrial fibrillation after right ventricular pacing and development of LVEF. This graph can be shows about from normal LVEF to low LVEF after start pacing that from unpaced to paced there is a reduction in the LVEF. And this is a pacing pace map from activation from apical pace to lateral and septal is a last part of activation. That means that leads to electrical dysynchrony. It's keep on pacing on the RV apex, it leads to mechanical dysynchrony. So these and all main factor, and after RV apical pacing, once we check it out, the regional delay by strain pattern analysis, you can see here from base to apex and lateral wall and septum, which shows lateral activating of after pacing. So the dual chamber and VVI defibrillator studies, which concludes, that is David study, which concludes death or first hospitalization for new or worsened in the worsened condition in the heart failure in 3 years. You can see here VVI have a more heart failure presentation than the DDR. Is compared with the VVI with the DDR. DDD have some sequential pacing, so the worsening of symptom comparatively lesser in the VVI. This electrical dysynchrony, which leads to mechanical desynchrony, which can be present as a remodeling, dilatation, development of MR after implant of pacemaker. So in Danish study also, which compare the AAI pacemaker with the VVI, of course that AAI doesn't have a RV apical, only AAI pacemaker which connected to the ventricle without pacing in the RV. So this study shows LV ventricular pacing definitely showing LV dysfunction and symptoms. You can see here that statistically significant difference in the AI compared with the VVI, but VVI compared with the DDD. In DDD, VVI is more than the DDD. DDD compared with the AI better than the DDD. So the conclusion in this most study where V pacing more than 40%, which leads to heart failure, and V pacing less than 40%, for each 10% reduction of V pacing, there is a 54% relative reduction of heart failure. That means in this study, not in the all group of studies, which shows if more than 40 percentage of percentage of pacing, which definitely leads to heart failure, and if less than 40, there is a point of reduction, but not much like more than 40%. And that very important one on QRS duration, shortest QRS duration has been used to identify the optimal site of pacing. It's studies from Harris and Swab in 1999, and the studies which shows QRS duration always reflect the activation front. Both study and Kudici in 2003 also its various site of pacing they compare. It's a lot of trials and individual trials they attempted, where in the study mixed response we can get. In this study they excluded indication other than the symptomatic bradycardia, selective patients population, only heart failure and epicardial placements. These are all excluded, and review in the beneficial of these all trials where it shows while randomized control trial suggests that LVEF is higher with the RV non-apical pacing than the RV apical pacing, there remains need to be large randomized trial to compare the safety and efficacy of RV non-apical to RV apical pacing. And like this, there is a lot of trials regarding EF reduction in the patient depends on the QRS. So in this another trial from Kim JH et al. In the BMJ, where the complete AV block in 15 years of follow-up study in electrical desynchrony due to QRS duration remains the biggest predictor of the pacemaker induced cardiomyopathy in long term. So once the pacing QRS duration less than 140 or more than 140, that shows much difference in the outcome in the LVEF. In this Kaplan-Meier graph, you can see if less than 140, which shows less QRS duration, less EF worsening of EF, and if more than 140 is higher possibility of developing heart failure. So the activation pattern once again. So left ventricular remodeling due to ventricular desynchronization. Desynchronization is due to functional and structural. First one is a functional asynchronous electrical activation, that is LBBB pattern. It leads to perfusion defect and mitral regurgitation, and also developing diastolic dysfunction, that is shows decrease in TP by DT and reduced to stroke volume, that leads to reduction of EF. And that long-term RV apical pacing or RV pacing which leads to structural remodeling that started from altered protein expression and myofibrillar disarray, which leads to remodeling like asymmetrical hypertrophy or dilatation. This kind of remodeling may develop. It leads to end diastolic and systolic volumes. This is a main pathophysiological part. So optimal ventricular pacing, which changing the paradigm, it leads to protect synchrony. After this development, which atrial based study and prevent desynchronization, it's a selective site like septal pacing, RVOT pacing. These both are doesn't so much difference in the outcome. And now we started direct his bundle pacing or left bundle pacing, and restore synchrony study which shows CRT, the best site for pacing in the human ventricle with abnormal electrical and mechanical activation from coronary vein. Then now we have a his optimized CRT and lot like a left optimized CRT, endocardial LV pacing and Y CRT. These and all recently we started doing, avoiding the electrical desynchrony leads to mechanical. So I will conclude by saying that ESG guidelines after 2021, there is a recommendation for patient with his bundle pacing as a class 1 and indication. Anyway, we know the CRT, and so I am not going to much about it. So the main important thing is conduction system pacing. We have class 1 indication with the level of C, and high ventricular case bundle pacing with ventricular backup may lead to pace and ablate strategy. Rapidly conducted supraventricular arrhythmia is indicated, particularly when intrinsic QRS is narrow. This is a class 2B indication. Anyway, that time constraint, so I will stop here. Thank you.
Thank you very much, Dr. Jayapandyan, for taking us through this. I think the floor is now open for discussion. I see Dr. Archie there and Dr. Shanmugasundaram also there. You can kickstart. I think there is some overlap between Shanmugasundaram's talk and Dr. Ajay Nayak about right bundle branch block. What are your thoughts, Dr. Archie, about RBBB LV dysfunction? What do you guys do now? Have you started doing?
So I think traditionally, I think the morphology versus width debate carries on, doesn't it really? I think it's about patient understanding that right bundle branches don't do as well. We're certainly not offering conduction system pacing in right bundle. If you have a wide enough QRS, and exactly as was mentioned in the preceding speaker, if you have a leftward axis, first degree, we know that the right bundles do better than traditional right bundles. The ones that really don't do well are the right bundles with the borderline QRS is the 120 to 130. I mean, I think, avoid pacing if you can in those patients. For me, if you have a wide QRS, you have a leftward axis, you have a first degree, then I think right bundle CRT is a goer, accepting that it's not quite the left bundle we all want. But that's, I'm quite a conservative operator. I don't, I stay well within the guidelines. And exactly as Shanmuga said earlier, his bundle pacing, conduction system pacing, we're very in the early days. The long-term implications, the threshold issues, there are lots we still don't know. So I think extending that further and further, we would do with some caution, for me personally anyway.
As far as conduction system pacing is concerned, so whenever we are planning for a resynchronization therapy for RBBB, whenever we find a prolonged HV, so in fact, it is the same case with the LBBB also. So almost 90-95% of the time, you'll have a prolonged HV in LBBB patients. That will give you one good sign that it's all electrical, not much of mechanical or peripheral component. Similarly, in patients with an RBBB, if you see a prolonged HV, I'll be the happiest person to do his bundle pacing or left bundle pacing. So regarding the order of choosing the therapy, whether it is a his bundle or left bundle, of course, his bundle is going to produce a maximal resynchronization by giving both LV, RV synchrony. But in left bundle, there will be a theoretical risk of intraventricular synchrony, especially if you have a baseline RBBB. So you can put additional leads in the RV septum, especially if you are planning for a CRTD, you can screw the ICD lead in the septum to have a a fusion of RB septal pacing as well as left bundle branch pacing. But like you said, again, we are in a very early stage of conduction system pacing. We need more and more data because we have come up with the data on RBBP, LV dysfunction, and left bundle branch pacing that we published soon. That will give some insights regarding the usage of conduction system pacing. Of course, the study by Dr. Parikshit was a wonderful one which have shown a significant improvement in LVEF. But if you go in an order, probably we have to start from his bundle because that is going to produce a better synchronization in RBB patient. So if it's not working, if the threshold is more than 1.5, probably you can go down into the septum, proximal septum to screw the left button.
My understanding of heart failure with LV dysfunction was pretty simple. I think doing CRT for last 15 years, and we all know that we are going to correct what is there, electrical dyssynchrony, whatever it's present. If anything is there in a right bundle to correct by doing a CRT, if the patient has a coexisting synchrony present on the left side, if by chance if your CRT is going to be non-inferior in correcting that, I think with other pacing technology, which is again going to correct left-sided dysynchronized, we are going to remain in the same place. Except that if you are going to do a CRT and you don't get really a good vein, you don't have good vein, you don't have a good QLV, then you can consider alternative pacing sites. Otherwise, I think our traditional experience with CRT, as Madam already told, that not all right bundles are pure right bundles. We see significant patients with right bundle, when you put them a LV lead and see QLVs in the range of 100, 120. We know these patients are going to really do well with CRTs. So I think that's the reason still ESC or all the guidelines continue to recommend CRTs on patients who have a non-left bundle branch morphology, because it's very difficult to pick these ECGs. ECG is just a manifestation of the peripheral manifestation of a dyssynchrony which happens inside the heart. So I would always keep all my right bundles evaluated, and the patients with a wider QRS, and when you get a good QLV in these patients, you know very well they are going to do well.
And any thoughts on the last talk? Dr. Jayapandian is here with us. Pacing-induced cardiomyopathy, all of us at some time, some stage, we happen to come across. What is the approach in Madurai, in Liverpool, and Kovai? And what do? You go for the extra lead back of the heart, or what?
Nowadays, that 10 years pacing patients now developed some mild LV dysfunction or moderate LV dysfunction. When we are planning for PG change, we are planning for left bundle area pacing now. That may be useful, and nowadays we stop pacing the myocardial one. Anyway, that Sanmosundran may give us some light on that.
In fact, the pacing-induced cardiomyopathy, the incidence varies depending upon the definition which you are going to use, whether it is an absolute decrease in 10% from the baseline value, or is a perfect decrement from decrease in EF of less than LV of less than 50 or 45. So, and beyond, and the other important thing is the duration of the pacemaker implantation. More the duration, more the incidence of pacing-induced cardiomyopathy. Of course, with the advent of conduction system pacing, the incidence of pacing-induced cardiomyopathy is going to come down. But for those patients who have already developed pacing-induced cardiomyopathy, as of guidelines, of course, like Laran sir was telling, BIV is the one which is recommended. But what we have observed is in our series, at least 11 patients are having pacing-induced cardiomyopathy. But for one patient, all other patients, they have shown significant improvement in their LVEF. And majority of the improvement occurs within the 3 to 6 months. That's what we have seen in patients with an LBBB also, baseline LBB also. So it's almost like a LBBB like a scenario where we are pacing the right ventricle and re-exiting the right ventricle. And so this conduction system pacing is one hope for this patient. And with the improvement in the tools, with the improvement in the evidence, if the level of evidence for recommending conduction system pacing for non-LV dysfunction patient goes up, then probably the incidence of pacing-induced cardiomyopathy will come down. So in our lab, at least we hardly put lead in the right ventricle. Only for left bundle branch area pacing is going to fail, then we'll put the lead in the right ventricular apex. Otherwise, in all our patient, bradyarrhythmia patient, dependent patient, we usually pace the left bundle for giving a correction.
I mean, I agree with what has been said both by Shanmuga and Jayapandian. I think as cardiologists, though, our first much as we must temper our enthusiasm for intervention by making sure that the pacemaker has been programmed right. And sometimes the basics are forgotten in our enthusiasm to do more and more. And we see this at battery changes, just going back to the indication for pacing, just going back to the fact that we're not short AV delay pacing, all the stuff that we take for granted all the time. Just ensuring that any RV reduction modalities that you can program is programmed. Because don't forget that everything that we need put in at some point might need to come out, and that carries a significant morbidity. So again, I'm just trying to be the voice of reason in a very exciting interventional world that we live in. Really, just
Yeah, I strongly support that. But you see, most of the studies which looked at RV pacing induced cardiomyopathy came in the era of all these modern algorithms. With the availability of all this ventricular pacing reduction algorithms, we see what we live in an era of like last decades. I think the number of pacing induced cardiomyopathy has significantly gone down. We could clearly see that once we started programming our pacemakers in an effective way, the number of pacing induced cardiomyopathy is look at my last 10 years and this 10 years when we started implanting a lot of this. I think one thing we have to educate our cardiology colleagues is to go for these devices. You see, like in India, I don't know about other places. In India, there is a possibility for you to go to these devices if you are interested, because not all the pacemakers available in India have this ventricular reduction algorithms. So you have to always go for the devices which have these algorithms on. And there are few algorithms which are extremely good. That ATM pacing based algorithms which are available in a few pacemakers are extremely good. I think with this, we have to really look at again at another 10 years to look at the real incidence of pacing induced cardiomyopathies. I don't see that the incidence what would be seen earlier, which still holds on with my limited experience. I would say that my personal experience.
I think the point you make is very elegant and valid, because remember also that once you start programming for HIS or CRT, you're shortening the AV delay significantly. So you're almost going to force pace. And when there's a clear indication, when there's a bundle branch, when there's LV dysfunction, you've made the case for the patient. But otherwise, just holding that little bit of holding back and just thinking, is this the right thing to go, is a good thing. But educating the wider community, those who program, the nurses, the industry support, and of course the cardiologists who are not perhaps as experienced as this forum really, about RV reduction is a good thing to do.
I would also to hear from Dr. Jaishankar sir. I think in the last slide and last word of Dr. Ajay Naik was very interesting point. He was talking about not to pace. That was one option he has given. See, with the era of huge data getting available on drugs available for heart failure, now I'm pretty amazed by looking at both ARNI and SGLT inhibitors as a drug for heart failure treatment. Do you see a option of not to pace these patients, the patients whom earlier we are very aggressive in putting a biventricular pacing on a group of patients whom we were not very keen, like a narrow QRS, right bundle, IVCDs, borderline QRS, because my personal experience also with these drugs have been very impressive.
Well, if you look at the guidelines, they are pretty clear that the pacing as an option is only on the background of GDMT. So the optimal medical therapy is paramount all the time. So that can never be taken away. All these newer advances, fancy stuff comes in after GDMT. And I mean, I guess as scientists, we better stick to that so we don't burn our fingers. And I'm sure all of us in this forum do just the same. And I don't really see the device coming down. I rather see them going up. The awareness is more. The technology is available. There are more and more centers, more and more implanters in our country. The ease of implant, and we are able to deliver better results for better quality and better well-being of our patients. So I'm actually looking at an upward trajectory as far as device usage in our country is concerned. And most of the industry colleagues are actually coming down on the prices of these not so affordable devices now. So it's very much within the reach of the common man in India, at least, where the insurance doesn't cover all the time. I think with that note, if there's no final word from any of us, I think I must thank each one of us here, Guru, Shanmugasundaram, Professor Archie, Lawrence, Jay Pandian, and the others who are watching. The customary thanks, because we've come to the end of this program. I got to jump to the next hall because there's a quiz going on there. I'm actually rather overwhelmed at the response to this electrophysiology meeting. We've had about 470 registrations, and close to 40 DM trainees are at the moment uh, breaking their heads on a very interesting quiz session based on the 2-day deliberation. And I'm very thankful to the international faculty, Professors Dheeraj Gupta and Professor Archie Rao, both good friends, mentors. Very thankful to our sponsors, without whom this program could not have been possible. The platinum sponsors, Medtronic, Boston, and Abbott. The gold sponsors, Sun Pharma, Zydus, Lupin, Bayer, Boehringer, and the silver sponsors, Torrent and Cipla. As I said, I reiterate, without their support, this could not have been possible. And very thankful to the audiovisual team, particularly Hallmark, the event managers, Seshadri and Vinay and the team, for bearing with me for the numerous changes I brought up in the schedule, the itinerary. I kept doing them, kept breaking their heads, and all the minute details which I'm sure I cannot cover now. Finally, a big thanks to Hyatt Regency Chennai, from where the meeting is being conducted. For uninterrupted, seamless transmission, we could finish the meeting well on time. Thanks to all of you. Goodbye, good day, and Jai Hind. Bye, Archie. We'll meet up sometime.
Absolutely. Take care, guys. It's been great to interact with you guys.
Great.
Bye-bye.
Same here. Bye-bye.